Thank you everyone for joining us for another Learning Lunch hosted by FormatApproved.com. My name is Brian Johnson. I'm the Senior Director of Online Training and Education with Format Approved, and I'll be your moderator today. Today's Learning Lunch will cover Don't Fear ICD-10. We're joined today by Dr. Evan Gwilliam of Find a Code. Dr. Gwilliam is a licensed chiropractic physician who is also a certified coder, compliance specialist, and medical auditor. You can see his credentials there on your screen. He has a knack for making coding and other complex issues engaging and easy to understand, and we're honored to share his expertise with you today. Before we get into our presentation, some quick housekeeping notes. We have a large audience for this Learning Lunch, and we'll try to save plenty of time for your questions. Remember that you can ask questions of our presenter at any time by entering them into the chat area during the presentation. We will hold those questions until the second half of our session, when we'll address as many questions as time allows. If we do run out of time, written answers to the questions will be posted to our website and sent via email link later in the week. Also, our guests often ask us for a copy of the slides. All registered attendees of today's session will receive an email with links to both the slides and the recorded version of this event, so don't worry that you'll get the copy of those slides. All right, let's go ahead and begin. First of all, thank you for joining us today, Dr. Gwilliam.
It's my pleasure.
All right, well, let's get right into it then. We've got a lot to cover. So why do we have to use diagnosis codes at all?
You know, I've taught ICD-10 all over the country, and I will continue to do so throughout the next 12 to 18 months. And I come across a lot of anxiety, a lot of concern over what's coming and how to change and what we need to do. And I just want to throw out here for those on the call that I hope that 40 minutes from now, your anxiety levels have gone down a couple of notches, that you feel a little bit better about ICD-10, and we're not going to teach you all you need to know, but you'll know what you need to do next. So if you'll take a moment and get a little bit philosophical with me, we have to step back and say, what's the point of these codes? Why do we even use them? And for starters, it's the law. We have to use them. So there may be some of you on the call who are providers, some of you who are billers, some are coders, but we have to use codes in order to be paid for the work that we do. And through HIPAA, it's required that we use diagnosis codes when submitting claims. And so codes were created originally in order to facilitate communication. If you take a bunch of people from different countries around the world and you throw them all in the same room, they may have a hard time communicating. But if there is one common language they can share, things may be different. And so codes are that common language. They're a way for us to meet together and then communicate between the provider and the payer and the clearinghouse and so on. So we're all using the same language. And so codes are used for a number of purposes. They're used to identify fraudulent data. You can compare codes statistically to look for fraud, for patterns. Diagnosis codes support medical necessity. They're the things that tell the payer that the reason that the patient was seen in the first place. And so they prove that the services were medically necessary. Codes also are used for research and clinical trials, and we'll see that ICD-10 will facilitate that even more so than ICD-9 ever did. They can be used to set public health policies as well, but probably most importantly for those of you on the call, diagnosis codes are used to process claims for reimbursement. And so we need to make sure we understand how to use them in order to get paid properly. They can also be used to measure quality and efficacy of care, and there are a number of measures going forward, and part of the reason that ICD-10 exists is to more effectively measure the kind of care that's being provided and help the government identify ways to do it more effectively and provide higher quality while hopefully reducing costs. So we have to use codes. We're stuck with them. They serve a vital role in the healthcare system in the United States when it comes to all these things, but my biggest concern, and for you today, is reimbursement.
So here's a question that may be on a lot of people's mind. Why can't we just keep using ICD-9?
Now, I was born in the 70s, and I'm a fan of the 70s. There was a lot of great music that came out of the 70s, the haircuts, the carpets, you know, the long orange carpets, the color that we used to paint appliances. I love the 70s. ICD-9 came out in the 70s, and it's one of the great things that we can, look back at nostalgically and remember fondly. But some things have improved since then. I don't know that we've come up with better carpets necessarily, but I think we've come up with ways to improve the code set. So 1979 was when ICD-9 was released. ICD-9 is the 9th revision of the diagnosis code set. It was actually originated more than 100 years ago, back in 1893, used to keep track of what people were dying from. And you can even trace it back to London and the plague if you want to go back even further. The point is, the current set we use has been in use for a long time, and it has limitations. There were things we couldn't foresee at that time. So a lot of the sections are full. The current ICD-9 code set starts with 000 and works its way up to 999, and then there's D and E codes, but that's a finite fixed range, and so some of those sections cannot be expanded. Many of those codes, which were created long ago, are not descriptive enough. They tend to be vague and general, and so there's a lot of limitations and problems that come about when we use codes that don't describe well enough what's going on. Many of you who know a second language, who've learned a foreign language, you know that some things just don't translate. Some things don't quite come across, and in some ways ICD-9 doesn't properly represent what's really going on in all situations. Now, ICD-9 also doesn't reflect the advances in medical knowledge or technology. The 70s, again, were a great time, but things have changed since then. We have the internet, we have computers, and so on, and so there's many advances in technology. We understand some diseases better, and so ICD-9 doesn't necessarily reflect those changes, and so it won't keep up with the needs of the future. Healthcare is continuing to change and adapt, and the way it looks today, I think everyone would agree with me, looks very different from the way it looked 20 or 30 years ago. Now, ICD-9 also requires excessive reliance on paper documentation. For those of you who are billers on the call, you may have had an occasion where a payer asks you for documentation to prove medical necessity. So they've received the claim, they've got the codes, but they come back and say, I need to see what the doctor wrote so that I can really understand what's going on here and decide whether or not it's medically necessary to pay for this claim. And so ICD-9 has that weakness, and ICD-10, as I'll show you, will address that weakness. So ICD-9, because it's not perfect and some of the codes are a little bit vague or general, it's like comparing apples to oranges sometimes. We can't accurately describe what a code means, so we can't compare it to other things to help us understand costs and outcomes. And so ICD-9 is limited in helping us understand how to better process claims and even deliver care in the bigger picture. So ICD-9, it's limited. It's time to update. It was time to move forward from the 70s into the modern times.
So what are some basics then that folks need to understand about ICD-10?
Well, ICD-10 is not new. It's actually been around for quite a while. It was introduced around 1990 by the World Health Organization, and it began use in 1994. So it's been basically used, at least it's the base, which is ICD-10, has been used for 20 years. Now, it was adapted for use in the United States and created what was called ICD-10-CM. The CM stands for clinical modification, and so it's taking this code set that's a bunch of diseases and it's making it more useful in a clinical setting. So the ICD-10-CM is the one we use for billing and reimbursement purposes. That's what Medicare uses. Now that hasn't been used yet. However, pretty much every other country, developed country around the world has taken ICD-10 and developed it for use in their country and have been using it for quite a while. And so we actually can learn from these other countries and their experience with ICD-10 as we move forward. And that may help with some of the hiccups we're facing. Now, ICD-10 has 5 times as many codes as ICD-9. And that's a huge increase. But as we go through the next little bit this morning, you'll see why that is and why that was really necessary. Now, I'm not even going to talk today about ICD-10 PCS, which is the procedure code set. That's only used in an inpatient setting. But if we include those new codes, there's 155,000 codes total instead of just 68,000. So today the focus is on physician-based coding or outpatient coding. So we have 5 times as many, 68,000 codes to worry about. A very important point, and hopefully you've heard this before, is that the codes are mandatory and must be used starting on October 1st, 2014. And you'll see kind of tongue-in-cheek, I've said for sure, maybe. I'll address this again a little bit later, but I'm working right now with a clinic, a large clinic here in Utah. They employ about 50 coders, and I've talked to them about approaching and training their coders and getting them ready for ICD-10. And what I've been told is that the supervisor for their department has heard that ICD-10 will be postponed again. It was postponed. It was supposed to be this October, but it's been postponed to 2014. And he's heard somewhere that it will be postponed again, so he's not going to get his people trained. And I think that's a mistake, because we have nothing to indicate that it will be postponed again. Everything that we've heard from the government says this date is for sure, but maybe because it has been postponed in the past. So it's mandatory. So basically, if you don't use the new codes on October 1st, your claims will be rejected. On September 30th, you can use ICD-9, October 1st, ICD-10. And those are some of the most important basics to understand with ICD-10.
And just to reiterate, CMS has been pretty clear, as you were saying, that they're not going to delay it again. So they could, but betting on it is a really risky bet.
Very true.
All right, well, what makes ICD-10 different than ICD-9?
So I'll give you some specific examples of these a little later, but there are a number of important features that coders and providers really need to start to get their head wrapped around so they can be ready. For starters, ICD-10 has expanded detail and specificity. One of the reasons for this is to eliminate the need for unspecified codes. Now, Medicare has told us that unspecified codes can and will still be used. However, as I'll show you some examples, unspecified codes will be less necessary because there are so many codes to describe situations. Odds are good you'll find one that matches. Now, again, we can use unspecified codes, but the need for them should decrease. And ICD-10 will give a lot more detail. ICD-10 is also alphanumeric. What that means is instead of just 3 digits and a decimal point and up to 2 more digits, of those 7 characters, some of them can be letters, some can be numbers. And what that means is now we can create a whole lot more codes. Instead of just the numbers 0 through 9 in one space, we can do 0 through 9 plus A through Z, except for U. We don't use the letter U, or maybe it's V. But regardless, there's a lot more codes to choose from. Plus, they're up to 7 characters instead of 5. So there's a lot more detail that can go into these codes because of this new structure. And we need to get used to looking at these codes and seeing what they look like. Laterality is a big deal. As I mentioned, the 1970s, in the 1970s, for some reason, we didn't realize that we have 2 eyes, 2 arms, 2 kidneys. We thought we only have 1 of everything. So all the codes in ICD-9 ignore the fact that there are 2 of things. And so if you take any body part that you have 2 of, there are now 2 codes for that. So you can see why there's so many more codes right away. There's a code for the right kidney and a code for the left. In every condition that you can have with the kidneys, there are twice as many codes because there's a right and a left. So laterality has been added to ICD-10. And some of you might be thinking, well, this isn't that big a deal. This is easy. And it is. ICD-10 is different, and there's more to it. But it isn't overbearing. It's not impossible to understand. There's also a lot more combination codes. In ICD-10, you may have had to use, or rather in ICD-9, you may have had to use a diagnosis of a condition and then a condition that's related to it, and you'd have to put 2 codes down. In ICD-10, they've created many more codes that combine conditions that often occur together. The diabetes section is a great example. There are lots and lots of combination codes of common conditions that occur with diabetes. And so now you can use 1 code to describe related conditions. This makes crosswalking a little bit of a challenge because there was no equivalent code in ICD-9, but there's a combination code in ICD-10. And so we'll look at a brief example of that in a moment as well. One of the biggest changes in the ICD-10 code set is the injury section. The chapter on injuries changed dramatically because it's now grouped by anatomical site rather than type of injury. And that's the example that many people mention when they talk about how different ICD-10 will be from 9 and how many more codes there will be, because the injury codes have expanded dramatically and they've been reorganized a bit. And so for those of you who work in emergency medicine or physical medicine, maybe orthopedics, you need to become familiar with the chapter on injury codes because that has the most changes. ICD-10 is also expandable. It's been modernized. It's using modern verbiage and phrases that we may not have used back when ICD-9 was created, and it's designed to be expanded. It can be built upon and drawn out. There are 21 chapters instead of 19, so it has all the same chapters that you find in ICD-9, mostly body systems, but they also separated out the eye and the ear into their own chapters. And they took the E codes and the V codes and threw them into a numbered chapter. And then there's also an X placeholder. So there are a number of codes that need to be 7 characters, but the 5th and 6th characters have no meaning. So in order to keep the 7th character in the 7th position, we throw in these placeholders. And I'll show you some examples of that later too. At the bottom of your screen, you see one example of just a classic ICD-10 code. And I want to point it out because I want to show you all the detail that it has. M1A.3120 is chronic gout. And the chronic gout is explained to us by the M1A, that's the category. The renal impairment is the character number 3. Left is the character 2, shoulder is the character 1, and without tophus is the character 0. So we learn a lot from, we can see how ICD-10 gives us so much more detail and perhaps replaces the need for extensive documentation. They may not need to ask for documentation to validate the medical necessity of this claim because it's all included in the code. So those are some of the key differences with ICD-10.
So those are some differences. How is ICD-10 the same as ICD-9?
Well, so for the coders on the call, a shout out to you, because I'm a certified coder as well. There are a lot of similarities. It's still a chronological list of codes that are divided into chapters that are based on body system or condition. So the first chapter is still infectious diseases, the second one is still neoplasms, and it goes on. It has the same basic hierarchy. So the appearance, if you've already done coding, it's going to be very similar. And they say that coders who already understand ICD-9 well will not have as hard of a time going to ICD-10. If you don't know coding and you got to start with ICD-10, it might be a little bit more of a learning curve. But it really bears many similarities. The index is the same concept. It's got main terms and you have subterms indented, so you still have an index. You look them up the same way. And in fact, the index is really the key to learning this code set, learning to use it. Now, the conventions are mostly the same as far as the use of phrases like code also and what a semicolon means and what parentheses mean. One exception is this new convention of excludes 1 and excludes 2. So certain codes may have an excludes 1, which means that it cannot be used with another code. Other codes may have excludes 2, which means it may be used with another code, but it doesn't include that code within it. So this doesn't apply to all codes in the code set, but it's something to watch out for and to brush up on, and you can find it in the guidelines if you need to brush up on it when you're looking through the code set and you suddenly see these. Now, so codes are looked up the same way. You look in the index, you find them, you search through the code set, and they're in chronological order. Just like ICD-9, codes are considered invalid if they're not coded to the highest level of specificity. So if you have a code with 3 characters, but there are other codes that have 4, 5, 6, or 7 characters, and you use the one with 3, that code will be denied. And that's one of the basics of ICD-9. Anyone who's coded for more than 10 minutes knows that you have to code to the highest level of specificity, which means you have to go to as many digits as you can if the code allows it. There are some codes in ICD-10 that only need 3 characters, but most of them need, well, 5, 6, or 7. Now, it's also the same as ICD-9 because ICD-10 is mandated. It was under HIPAA where we used ICD-9. HIPAA says we got to keep using ICD-10. And so, if you don't want to learn it, that's kind of too bad. It's coming, and to be honest, it is better. It's a better system. It's a better way to communicate, and so it was an improvement we needed to make. And I may be a little biased, but I think it's it's fun to learn, and it actually works really well.
So I love some of these examples. Maybe we should start with some of the most useful of the new codes.
So one of the expansions in ICD-10 is the external cause codes, which were E codes back in ICD-9, and they're found in V and W, and so some of them are pretty entertaining. It's hard to find humor when it comes to coding, and so when you do find it, you've got to latch onto it and make sure that you exploit it as much as possible. So here's a few codes from ICD-10 that you may not use that often, but they're real codes, I swear. So V95.42XA is spacecraft crash injuring the occupant, the initial encounter. So for those of you in practices where you do a lot of spacecraft-related injuries, you have a way to code that now. Struck by a turtle, you may use that code quite a bit. By the way, to illustrate a real point, you can see the placeholder X in these codes. Those are placed in there. They don't have meaning in and of themselves, but the last character, the A, needed to be in the 7th position to maintain its meaning. So the X was placed there to hold it. And there may be a day later on where we need more detail about being struck by a turtle, so they have the ability to put numbers and letters in that space if they so choose. G44.82, headache associated with sexual activity. I'm not going to talk any more about that. I think it goes without saying. So V91.07XA, you can find a video of this one on YouTube, and it's a picture of somebody on a jet ski. They're on fire. They're cruising around, having a good time. So, it could happen. There are situations perhaps where someone who's water skiing or using a jet ski may indeed set on fire. And then you can see, maybe you have heard lightning doesn't strike twice. T75.01XD, shock due to being struck by lightning, subsequent encounter. Now, the truth is subsequent encounter actually means that the doctor is seeing the patient a second time for the same condition, but it kind of implies that someone's been struck twice, so it's kind of fun. And then Y34 is that code that catches everything. Unspecified event, undetermined intent. So it doesn't tell us anything at all. So there are a lot of codes that you might think are a little bit extraneous or superfluous, but there's a great deal of detail in ICD-10. And I'll show you some real examples here in a moment, some other examples that you might actually use more commonly in your clinics.
So in these examples, those 7th digits there are coding the encounter, which is an interesting feature.
And actually, and I kind of skipped over that before, if you look at the A means initial encounter, D means subsequent encounter, and S is another very common third character, which means sequela, which is a late effect or a condition that is resolved but still has residual symptoms. And so the 7th character is special, especially in injury codes. There's a lot of special 7th characters for injury codes.
So here is...
And it'll really just take some getting used to it.
Sure. So here is sort of the million-dollar question. How do I find the right ICD-10 code to use?
Great. So you've done your homework. You kind of get what ICD-10 is. You know how it looks. You understand the organization. If you've been ambitious, you've actually read through the guidelines at the beginning of the code set, which I strongly encourage for serious coders, not necessarily for everyone, but coders should certainly read the guidelines. They're very similar, by the way, to ICD-9, but it's important to review. You've got the basics. Now it's like, okay, but really, where do I get the code? How do I know what I'm going to use on a claim? Well, the government knew people would ask this question, and so they commissioned the National Center for Health Statistics to create GEMS. And GEMS has been around for several years. It stands for General Equivalence Mapping Systems. Now, they've had this disclaimer on there. They said this is not used for coding. In other words, they've created a map. They've made a list of all of the ICD-9 codes and the equivalent ICD-10 codes. And you can just look them up. If I use this code before, here's the new code. But this is intended more for statistical analysis, for a starting point, for claims, but not for coding documentation. And you'll see why as I give you these examples. So this GEMS, this mapping system, is available in the public domain. You can go and get it right now from the CDC. It's on their website. You can download it. Several companies have gone ahead and taken it and put it into a format where you can plug it in and use it. And some software vendors have also plugged it into their software, their EHR, and so on. And I have a word of caution for you. If you use a software system that only uses GEMS, it's not taking you all the way to where you need to go. It's a useful starting point, but you can't say that you're done and you know all there is to know about ICD-10. There's a little bit more due diligence that you must follow in order to properly end up on the right code. So let's just take some examples. The first is a one-to-one map. If you take the code for cervicalgia in ICD-10, it's 723.1. You plug it into GEMS, you look it up in the database, or use one of these free online tools, and you get M54.2. M54.2 is the ICD-10 code, and it means cervicalgia. That one is black and white, cut and dry. The old code was 7231. If you're going to use cervicalgia in the future, you're going to use M54.2. No problem. Now let's look at another example, 1 to 3 mapping. There's a code for spotting complications during pregnancy. In ICD-9, it's 640.51. If you plug it into GEMS, it will tell you there are 3 possibilities in ICD-10. And they essentially have the same definition, spotting complications during pregnancy. But the code that ends with the digit 1 is for the first trimester, the digit 2 is second trimester, and the digit 3, the one that ends with the digit 3, is the third trimester. So if you look up any obstetrics code, there are basically 3 times as many now because they've created a code for every trimester of pregnancy. And again, you can see why there's so many more codes in ICD-10. So here's a little bonus. In ICD-10, all the obstetrics codes start with the letter O, which is kind of nice. So if it's obstetrics, it starts with an O. So there are further examples. If you look at the bottom example on your screen, 962.9 is poisoning by hormones. If you plug that into GEMS, GEMS tells us there are 16 possibilities in ICD-10. And so it's not as simple as the software replacing the old code with a new one. You're going to have to go and look at all 16 of these codes and figure out which one might apply. But this isn't the end of your troubles. It gets a little worse. If we continue, we'll see that there are some codes like 733.82, which stands for other disorders of bone and cartilage, and it actually points to 2,530 possibilities in ICD-10. So this is, I think this is the worst example in all of ICD-10, but the codes range from S02 to S92 and everything in between. There are more than 2,500 possibilities. So you can see that GEMS simply can't get you where you need to go. And to go a little further with this, there are also combo mappings. So a code that I use when I do audits for clients and so on that I see quite a bit is sciatica, 724.3. That's the code you use when someone has sciatica when you're using ICD-9. If you plug it into GEMS, GEMS will tell you that the code you should be using in ICD-10 is M54.30. That is the code in ICD-10. It's sciatica unspecified side. Now, if any of you on the call have ever had sciatica, you know that it's really easy to tell which side it's on because it's the side that hurts like crazy. And so sciatica, by the way, is a neurological radiculopathy going down the back of the thigh, sometimes all the way down to the heel. And so if you use the GEMS mapping, it points you to a code that most payers are going to have issues with because that implies that your provider didn't bother asking the patient if it was their right leg or their left leg. And that's just sloppy. In most cases, I would argue that you should be able to tell whether or not the patient has a problem on the right or the left. So if you actually open your code book and you look around, you'll find that there's an M54.31, which is sciatica on the right side. M54.32 is sciatica on the left side. And if you go a little further, you'll see that there are combination codes now. M54.41 is sciatica that includes lumbago, which is low back pain, and that's on the right side. M54.42 is sciatica with lumbago on the left. And so none of those codes were given to me by GEMS. GEMS simply doesn't have that information. The way I found these codes, frankly, was I just looked them up. And I was just looking around in the book, reading for fun through my ICD-10 code set, and I found these. And I thought, oh, well, that's good to know. There's now a combo code for sciatica with lumbago, and I didn't know that before. And so providers have to learn to document this information, including right or left, whether or not there's these combination codes that might apply. And so that's going to take a little bit of homework on the part of the providers and those doing the billing and coding. Now, in some cases, there's no code at all. If you do autopsies in your clinic, 89.8 is a procedure code from ICD-9. It's actually volume 3 code. There is no equivalent code in ICD-10, so no more autopsies for those of you who like to do those. Or at least you can't code for it in ICD-10 CM. So Medicare tells us don't use GEMS to pick your codes. Use GEMS to get started and then dig a little further. Use the index in your coding books to find the answer. And that's an important distinction. it's not going to be that easy. You can't learn to speak in a foreign language by simply translating word for word from a sentence. You have to know the syntax. You have to get the agreement between the gender with certain words and so on. And ICD 9 to 10 is a bit like learning a new language.
So what are some myths then about ICD-10? I think there's a lot of rumors going around in preparation of the transition. Maybe you could share some of those with us.
And what I anticipate here is that I'm going to answer some questions that may have come in or will come in here by the end, because these are the things that people commonly ask about. And let me give you a reference here. You'll see it on one of the slides, but most of these answers I got directly from Medicare, and you have a reference on one of the last slides that'll help you find the document with more detail about the answer to these questions directly from Medicare. So many of you may recall Y2K and how that was going to be the end of the world, or some of you last winter may have thrown a party on December 21st because you heard about the Mayan calendar and how it predicted the end of the world, and we were going to be done. Well, I'm still here, you're still here, so we're moving forward. ICD-10 will not be the end of the world, so it won't be delayed again. However, if anyone wants to throw an ICD-10 party, invite me. I'm all over it. I'll be there. The date will not be delayed again. The rumor is going around that it will be, and that rumor will continue to go out for people who don't want to spend the time and money to figure it out. Medicare has assured us, let me give you a quote, the Department of Health and Human Services has no plans to extend the compliance date for implementation of ICD-10, CM, or PCS. October 1st, 2014. That's a direct quote from Medicare. The resource that I got that from was published in April this year. There's nothing out there to say that they will delay except for the past history of delaying. Now, how about this rumor, workers' comp and auto insurance will still use ICD-9? So you may know that HIPAA is the thing that requires us to go to ICD-10, and HIPAA does not apply to workers' comp and many auto insurance companies. And so technically they are not required to go to ICD-10. But if I was a workers' comp organization, to be honest, I would not keep using ICD-9 because the code set's not going to be updated anymore. Everybody else in every other healthcare profession is going to be using ICD-10. So they do not have to, but if they don't, they're behind the ball. And odds are very good that most workers' comp and auto insurance will adapt to ICD-10 and move forward. And Medicare will work with them to help them and encourage them to do so. How about the rumor that Medicaid won't have to do it? You know, there's state-run programs and Medicare is federal, and HIPAA says that Medicare has to do it too, and Medicare will work with state Medicaid programs to make sure that they're ready as well. So Medicaid's going to be on board. How about ICD-10 is so darn big, we won't be able to use it. We just can't keep track. You know, what's more useful to you, a dictionary that only has 100 words or a dictionary that has 100,000 words? Right? A bigger dictionary isn't harder to use. It actually provides you with, it makes it easier to find what you're looking for. So a bigger code set may actually be easier, and there are plenty of electronic coding tools. There's the alphabetic index, and the code set has better structure and specificity, and so electronic tools will have a better odds of being able to find us the right code. So it'll be manageable, but it will take a little bit of due diligence and homework. How about documentation? You may have heard horror stories that ICD-10 is going to be impossible to figure out because it's going to require so much documentation. It's going to take our doctors all kinds of extra time. I can't recall where I read this recently, but I believe there was a study done that estimated to be 15% more time will be required on documentation. And to be honest, yes, it will require a little more. But I think asking doctors to do a better job of documenting what happened is not unreasonable. I think doctors should be documenting what happened. And so if you've never documented right or left sciatica, I don't think it's going to be hard to be able to add that to documentation. So documentation requirements will be a little bit stiffer, but it's basically going to take a little bit of work on the part of the provider to understand what they need to be writing. And coders may be instrumental in the education piece of that. How about ICD-10 is already out of date? I told you it's been around since 1994. You know, so maybe it's no good anymore, and you may have even heard the rumor that we're going to skip ICD-9 and go to ICD-11, or we're going to skip 10 and go to 11. There is an ICD-11, by the way, and it's actually the preliminary use of that is going to be launched in 2015. Its biggest difference between 11 and 10 is that 11 will be electronic and be updated instantaneously instead of a couple times a year. But essentially, 9 to 10 is a big jump. There's a lot of differences in the code, like the number of digits and use of letters. And so moving from 9 to 10 is a natural progression. 9 to 11 is too big of a jump. the AMA pushed for this, pushed for skipping to 11, and they were shut down by Medicare. And so the ICD-10 is not out of date. It's been updated annually since it was released until 2011. The last time it was updated was 2011, and then it's been frozen since 2012, and it'll be updated again starting in 2015. And they froze it to make it easier for us to adapt to it. Now, one other rumor is that CPT will be replaced by ICD-10 PCS. So ICD-10 PCS is the procedure codes that ICD-10 provides, and Medicare flat out says no. ICD-10 PCS is for use in inpatient settings only, and the CPT code set for outpatient coding will continue to be used as it has been. And so ICD-10 has no impact on procedure codes for use in outpatient physician settings.
So this is another question that's probably right on the top of a lot of our audience's minds. What do they need to do right now to get ready?
And so, you know, we're going to finish this call in a few minutes, and you're going to say, okay, I learned a little bit about ICD-10, but what do I really need to do next? You need to start doing some training. You need to find resources for training, and we'll show you some resources here in a moment. Coders need to learn anatomy better. If they didn't know anatomy before, it's even more critical for them to understand anatomy, especially some of those injury codes. They get really complex, and they have to understand different parts of bones and the names of various pieces of organs and so on in order to properly understand the codes. Providers need to learn the documentation. So once the coders know which codes their provider needs, they can use the third bullet point there, you know, create your own super bill. So look at the codes you use right now, start with GEMS, and crosswalk and figure out the codes that GEMS point you to, and then one by one go through those codes and look them up in your ICD-10 book. You're going to need to either use an online service or buy an ICD-10 book and look and compare and create a new super bill with the new ICD-10 codes, and then go to your provider and show them what those codes are and have them learn what needs to be documented for those codes to be used. Those steps may sound a little bit overwhelming, but if you do a little bit every week at a meeting or something, it can become more bearable. When it comes to budgeting, the RAND Corporation released a study a few years ago, and they said it's going to cost 40 grand for a typical mid-sized clinic to get ready for ICD-10, between training and software upgrades and so on. But they throw in there that small clinics may be 4 grand. So you need to think about budgeting. The AAPC, the American Academy of Professional Coders, actually recommends that clinics save 6 months of operating income in order to be prepared for the possibility that payers might not be ready. You know, October 1st will hit, and it's possible that when you send in claims, you might know your codes, your provider might be doing their documentation, but it's possible that the payers may not be ready. And so if that's the case, the advice is that you may have to save up a little bit of a rainy day fund. 6 months seems excessive, but be prepared for a cash flow issue when that hits. It's a possibility. And then it's very important for you to contact your software vendors. Talk to your clearinghouse, talk to your EHR, see what they're doing, and ask them when you can submit test claims. Ideally, spring, summer next year, you should be able to submit claims with ICD-10, test claims, and have them process them and see what happens. That can be very useful. Oh, and I skipped. Check all your forms out of ICD-9 codes and update them. Do your own crosswalk, start with GEMS, and then pull out a book and look around and see what else there might be. Update every form you have. Get them ready before the date. Don't wait until a week before. Don't wait until next September. Start doing this by January, you know, this next year. Start moving through this process until your office is ready and you're just waiting for the rest of the world to catch up with you.
Yeah, so I think the theme here may be don't wait until September of 2014, to say the least.
Definitely not. Don't stick your head in the sand.
So where can folks out there learn more about ICD-10 and the coming change?
There are a million companies out there willing to provide you with information on ICD-10. And to be honest, a lot of it is free. You can get this on your own. Medicare, whatever you think of Medicare, I can tell you that when it comes to ICD-10, they have put out a lot of great information and training on this. And so you can sign up for email updates. That's that first link that you see on your screen. The myths and facts that I was talking about earlier, you can find a Medicare document that explains various myths and concerns with ICD-10, and there's a link there. Medicare has lots of great resources. They do training. I believe they did a broadcast on ICD-10 basics last week. You know, they are all over the place with ICD-10, so you can't say it wasn't out there. They're putting a lot of effort into it, and I think that most of their stuff is very helpful. Now, findacode.com, my employer, has crosswalks and other tools. We've taken GEMS and put it into a database for you. And so you can go in and plug in your ICD-9 code, and we'll tell you what the ICD-10 should be, and you can click through and look at what the definition of those codes are. And so FindACode has some great tools. ICD-10monitor.com is one of the authorities in the private sector on ICD-10, and I write articles for them. I'm on their editorial board. ICD-10 Monitor hosts a weekly talk show called Talk 10 Tuesday. They interviewed me last week, and it's actually got a lot of people that log into that. And they have people all over the industry, experts they interview. It's a 30-minute call every Tuesday. You could do that every week just to help you brush up. Or you can just go in and read their articles. It's a great resource. And Format Approved has their own training that you can go through to get you prepared for ICD-10. And perhaps Brian would like to speak more to that. But let me throw in AAPC and AHIMA are other authoritative resources. Those are a couple of coding organizations that offer credentials and training for ICD-10. There's lots of information out there, lots of free stuff, and lots of agencies willing to take your money if you would like to harness the expertise of others. And so there's lots of resources out there for you.
And I'll go ahead and tell people about that training after we've tackled some questions from our audience.
Great.
And we've saved plenty of time for questions. We've already got a large number of them. Before we dive into those questions, I'd like to remind our audience, for those of you who have asked, that we will be sending out a follow-up email that'll have the slideshow you've seen as well as a recorded version of this event. So watch your email box for that information. And let's go ahead and ask our questions from the audience. And again, I'd like to remind the audience that if we don't get to your question, we're going to follow up with written answers, so don't worry about that. First question, I think this is an easy one to answer. When will the ICD-10 manuals be ready? They're ready now, isn't that correct?
They are. You can go and buy them from Elsevier, Optum, Ingenix. AAPC sells them directly, and they look good now. If you bought them a year or two ago, they were available. They were draft code sets. But the ones that they've released now, they've added color. The formatting is great. They're fairly easy to understand once you get the basics down. So they're out there, and they're about they're less than $100.
All right. Here's a question I think you might enjoy about sciatica. What about sciatica bilaterality? Is there a code for that, or do you use both right code and left code?
I can't recall. I'd have to look at the code set. But basically, if there is a code for bilateral, you would use it, and if there isn't, yeah, you would have to list two codes. I think that there is not a bilateral code for that one.
All right, and of course, I was just going to say
that may be a way that the code set improves in the future. Maybe that's something they'll add.
And when we follow up in the written responses, maybe we can get more detail on that as well. Here's another question. When can folks actually begin using ICD-10? Do they have to wait until October 2014?
Yes. If you submitted a claim in next August or September with ICD-10, it would not be paid, at least by Medicare. So the only reason you would submit a claim with ICD-10 on it is for testing purposes prior to that date. It's going to be a clean break as far as we know at this point in time.
All right, let's go on to another question then. Here's a question from someone who works in a mental behavioral health care setting. They would like to know, how is the change to ICD-10 going to affect workers in that environment the most?
Well, the same as everyone else, in that there will be new and expanded codes, significant differences. I can tell you that there are specialty books available. For example, I have helped write a specialty book on ICD-10 for chiropractic, and there's a sister company that I'm employed by that has a behavioral health ICD-10 book that's already available. And so if you'd like, I can help you find that. If you want to contact me, we can sort that out later. But there are specialty books on some ICD-10 topics, and I know for a fact that there's one on behavioral health because our company has one.
And I would add to that I know from our own training that there's been some significant changes to the coding for dependence on substances. I know that's one area where there's some changes.
That's very true. In fact, in the guidelines in the ICD-10, there are a number of rules around how you would code dependence on substances and so on. And so those guidelines, that's one of the examples of where the guidelines have been updated. That's correct.
So they should definitely look into that that specialty information you were mentioning
Mm-hmm.
just now. Okay, here's another question. I'll just read it. If I could ask one quick question about coding specificity, I've heard that we will have to code so specifically that it will be impossible to do it correctly. That may be along the lines of the myths you were mentioning, such as for a sacroiliac sprain or strain, we will have to be selecting specifically which ligament is injured, which can be almost impossible. Is this true?
Um, yes and no. Um, there are codes with sprain strain where they list specific ligaments. It's true, and the argument is, how am I going to know that without advanced imaging like an MRI or a CT scan? And it is a bit of a challenge, and to be honest, we're not quite sure how that's going to pan out. So where you had one code for a sprain of a certain joint, now you may have 4 or 5 codes, and they list different ligaments. The ankle's a great example. You need to know which sprain, but you can also use an unspecified code in that case and state that you didn't feel it was justified perhaps to do the advanced imaging just to figure out whether it was the deltoid ligament or another one. So that one is a mixed bag, and we need to kind of wait and see. A lot of what ICD-10 is, here's what we have now. Some of it we're going to find out October 1st how it's really going to work. And so there are some issues like that are so specific, not quite sure how that's going to work just yet.
All right, here's a question. I'm not entirely sure I understand it, but I'm going to let you take a whack at it and see if we can answer the person's question.
All right.
The question is, what about ICD-9 codes given prior to October 1st? Will they have to be changed to ICD, or does it apply to all new directions, or given after October 1st? It's DXs, I'm not sure.
I think I understand diagnoses.
Oh, I see.
If I understand what they're asking, so let's say a patient goes into the hospital on September 28th and they leave on October 4th. How does that claim look? Medicare has released one of their newsletters a month or 2 ago, and they explained for dates of service prior to October 1st, you use September 30th. For dates of service after October 1st, you use ICD-10. And so it's a very like I said, it's a fine line. There's no gray area there. What about resubmissions? A date of service occurred on September 28th, and you don't submit it till October 10th. It's based on date of service, not the date of submission. So hopefully that addresses that question. And Medicare has information available about that too.
And remember, when you get the slides for this presentation, you can go and look at the resources that Dr. Gwilliam provided earlier as well. Okay, here's another question about meaningful use. I've heard, or have you heard anything rather, about not being able to attest for stage 2 of meaningful use if you're not able to crosswalk to ICD-10 by January 1st, 2014. I heard someone say this at a meeting. Just wondering if you have heard this, or are they misinterpreting something?
I have not heard that. That is a great follow-up one that I will look into and talk to some of my EHR friends, and I don't know.
No,
I've not heard anything to that indicates that, but that doesn't mean it's not true, so it's worth looking into.
We haven't heard that here at Format Approved either. It is an interesting point, that the vendors are going to be upgrading their systems for Stage 2 compliance throughout 2014. That's why there's a reduced reporting period. And so it shouldn't be an issue for them to have ICD-10 live in their systems by then. But it's interesting. I don't believe it's a requirement of Stage 2, but that would be an interesting one to follow up on.
And here's some advice someone gave me with regards to software vendors. If you call them and ask them, what are you doing for ICD-10, and their answer is, we're working on it, you should go find another software vendor because they should already be there. They have the data. It's available. And so you should be working with vendors who already know what to do with regards to ICD-10.
Yeah, that's a great point. And what we've heard from our meaningful use experts is you should already be talking to your vendor about the transition to Stage 2 anyway. So this is a conversation that you can have with them as well around ICD-10. Here's a question about denials. And the question is, can you anticipate what the reasons for claim denials will be. If coded correctly, what will the health insurers deny for? I would like to start templating appeal letters and the like.
Good way to be on the ball. I can speculate, and here's my guess. You take a code where there was only one ICD-9 code, and now there are two ICD-10 codes. One example is, I believe it's cervical sprain, has one code that lists all the specific ligaments, and another one that says other ligaments. So we know that the ICD-9 code was covered, but the question then becomes, in ICD-10, will it cover both of the two codes that are crosswalked, or will it only cover the one with the specifics? And we don't know. We simply don't know yet. We need to wait and see. So can we guess how many of them will be denied, or how we don't know what the payers are going to do. What we do know is what you can make sure you understand the code set, and you know what the possibilities are, and you're prepared for them, and you know that you've worked with your vendors, and you've got everything, all your ducks in a row, and so that when it does come time for denials, it's not your problem. You know it better, or as well as the payers, who may be dragging their feet about coming up with their list of which codes they'll accept and approve. So that's the best you can do, is you know it as well as you can, and wait for them, and then you get on top of it, because they may or may not be totally ready. We don't know. We just have to wait and see.
Here's a great question from a planning perspective, and it's they want to know whether you have a recommendation for the amount of time it will take to train current coding staff up to ICD-10.
Sure. So I recently completed the ICD-10 instructor certification through the AAPC. I'm a coding instructor. I teach certified coders all the time. A couple of weeks ago, I taught 2 hours to certified coders to help them get ready for the proficiency assessment, to prove that they're ready. The AAPC suggests about, well, it depends on the scope of your coding, but if you need to learn the entire code set, 20 hours. That's what the AAPC is kind of recommending, give or take. But if you're specialty specific, you can learn the basics, like what we went over today, go into a little more detail in a couple of hours, and then it's just a matter of doing cases that are specific to your specialty and learning the guidelines that apply to, like behavioral health, because they have a few extra guidelines. But once you've read, there's only a couple of paragraphs on those guidelines. You read them, you study them. What I recommend to my clients who are I go around the country and I teach chiropractors how to get ready for ICD-10 as well. And they're talking about having me do a 6-hour one-day training. I think within 3 hours I'm going to have it done, though. So I'm going to have to come up with other things to teach, because I think the basics, the function, 3 or 4 hours, and then it's just a matter of doing cases. And what I recommend is take some cases you've already done, claims you've already submitted in ICD-9, and for practice, recreate them. So maybe dedicate 10 minutes a week until you feel like you know it really well, and just do practice cases and go through the basics at first, and then do practice cases with real cases in your office until you know all the possibilities, and do that from now until next October. 10 minutes a week, you'll be ready, in my opinion. Coders have a jump start because they already know ICD-9.
Here's a question about regional extension centers, and the question is, do you know if they plan to provide assistance around ICD-10 the same way that they do for meaningful use?
I'm not familiar with...
I was going to say there's a million of them, so it's kind of hard to answer, but...
in terms of ICD-10, Medicare, as I said, has provided lots and lots of stuff out there. And you can find a lot of free information on the web. ICD-10 Monitor has all the articles and such. So training and all that should be available. If you're dealing with Blue Cross and you're submitting claims, it's in their best interest to make sure the system is working too. So I would assume that all those resources are going to be there and will be willing to work with everyone and help.
Yeah, what I would recommend there is just, your regional extension center in your area should have a website. Go or call them up or email them and just ask if they are going to provide resources around ICD-10. It's definitely an interesting possibility, but it probably varies by the rec. Here's another question about electronic coding tools. Can you recommend any of them? I think you may have one in mind.
Yeah, okay. Find a code. And findacode.com, you go in there, we'll give you a little opportunity to do a free trial here. We can do a demo for you and show you all the things that it can do and how it can help you get ready for ICD-10. But, Find a Code's my favorite for obvious reasons. I have a lot of input on how it's structured and how it works, and so I'm proud of it, and I think that I know how to use it, and I think we've created a tool that is easy for others to use. So. And by the way, let me throw one more thing at you. Get on your smartphone or your iPhone, your iPad, download the app that's called Find a Code. It's a free ICD-9 to 10 crosswalk. You can do a free trial and use the full software on the website, but there are free apps from Find a Code, and you go download it right now, and you can use that as a starting point. It has gems built into it, and it's free. So go ahead and do that at your leisure and try it out.
Well, I'm happy to say that we got through most of the questions. We didn't get to quite everything, but I want to thank you, Dr. Gwilliam, for answering those questions, and we will follow up, as I was saying before, with some written responses for folks.
You bet.
Well, as Dr. Gwilliam was just mentioning, you can log in to www.findacode.com to try a free trial of their ICD-10 tools. So definitely take advantage of that. We are big fans of Find a Code here at Format Approved. I want to thank you again, Dr. Gwilliam, for joining us. It was a great session. We've had a number of comments from folks saying it was a great webinar.
Terrific. Glad to help.
All right. I'd also like to thank all of our attendees. Remember that all registered attendees will receive an email with links to both recorded and PDF versions of this session. Are you a coder who needs bridge training from ICD-9-CM to ICD-10-CM? One of the resources you may want to consider is the Format Approved Certificate of ICD-10-CM Coding Proficiency, our CICP course. You can learn more or register at www.formatapproved.com/education/courses_CICP.html. Visit formatapproved.com to learn more about our other upcoming learning lunches. The Learning Lunch button will take you to our entire slate of upcoming webinars. Our next Learning Lunch will air tomorrow, August 28th, and we'll cover the subject of Stage 1 EHR alternative, keep your paper charts. So to a meaningful use guy like me, that sounds controversial. I'm sure it'll be an exciting session. Thank you, everyone, for joining us again, and keep an eye on your email box and our homepage for other upcoming Learning Lunch topics.